Very good morning, ladies and gentlemen, and welcome all of you for yet another Sunday morning academic session organized by the Sri Academic Center. Today, we have a very interesting lecture, and just before that, let me introduce you to some of the housekeeping agendas. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in, and we strictly monitor no late attendees will be entertained after 9:50 a.m. Each attendee should have been attended till the end of this webinar to obtain the certificate for CPD points. And as we all know that the CPD points are strictly adhered to the NCCPD guidelines. This is just to improve and maintain the standards of the CPD program conducted by Society for Health Research and Innovation. And thank you for strictly adherence of the CPD regulations. And let me kindly remind all of you about not to start your videos as well as not to interrupt in between this webinar series. The questions can be directed to us through a chat option, and we will discuss all the questions at the end of this program. Ladies and gentlemen, as I said, today we have a very interesting topic on our hands. It's on management on osteoarthritis of knee joints, a common enemy in sports and medicine approach, in the purvey of sports medicine approach. I would like to invite Dr. G.D. Mithila Ruwanga, a senior registrar of sports and exercise medicine at Colombo South Teaching Hospital, a prime graduate from the University of Colombo Faculty of Medicine, as well as a former secretary of Sri Lankan Sports Medicine Association, and not to forget, the team physician of Sri Lanka Police rugby team. There's no one better to talk to you about OA of the knee joint than him. Sir, the floor is yours. Thank you very much.
Good morning to all of you, and thank you very much for that kind introduction. And first of all, let me thank Sri and Mr. Dr. Vasan, who invited me to do this lecture. So today I'm going to talk about the management of osteoarthritis of the knee joint, sports medicine approach. I'll be taking you through the little bit of anatomy of the knee joint and biomechanics of the knee joint a little bit, pathophysiology of osteoarthritis of knee, clinical features of osteoarthritis of knee, how we are going to diagnose osteoarthritis, and radiological features. What are we going to see in the X-rays of an osteoarthritic knee joint, and what is the classification of that osteoarthritis of knee joint, and of course, the sports medicine approach of managing a patient with osteoarthritis. First of all, let's see a little bit of the anatomy of the knee joint. The knee joint is made up of bones, muscles, ligaments, maybe tendons, and meniscus. Bones per se, there's femur, tibia, fibula, as well as the patella. And muscles, anteriorly, there's quadriceps muscle. Posteriorly, there's hamstring muscle, as well as the gastrocnemius muscle also. And the ligaments, mainly the anterior cruciate ligament, which is inside the knee joint, and the posterior cruciate ligament, as well as the lateral and medial collateral ligaments, which prevents any displacement of the knee joint. And also there are menisci, medial and lateral menisci, with articular cartilage, synovial fluid, and animal membranes. And not to forget that there are 3 functional compartments within the knee joint. Those are the patellofemoral joint or the patellofemoral compartment, and the tibia-femur compartment can be divided into lateral and median compartments, where laterally the lateral meniscus is there and medially the medial meniscus is there. So that's the basic anatomy of the knee joint. When we talk, then we will talk about a little bit about the biomechanics of the knee joint. In a standing person, the line of gravity goes in between the legs like this. In between the legs like this. But the forces or the weight goes to both legs equally. Not to mention that it goes to the knee joint. And within the knee joint, the weight or the forces go through the medial compartment of the knee joint. As I showed you earlier in the knee joint, there are two compartments, the lateral and medial compartment. The forces mainly go through the medial compartment. During walking, our line of gravity shifts from side to side, from right to left, like this. So when the line of gravity shifts from right to left, the forces going through one knee increases markedly. Therefore, the action of the knee joint mainly is to do the walking or the locomotion. So while walking, the forces going through the knee joint, mainly the medial compartment, is much more. And during walking, multiple forces act on the knee joint. I will show you. And multiple forces act on the knee joint, and mainly the body weight, the ground force reactions, and the muscles contracting on the around the knee joints. As I said, the quadriceps and the hamstring. So there will be multiple forces acting on the knee joint. Because of these multiple forces, the knee is forced to have 6 types of motion in different directions. In this picture, you can see that the knee joint is forced to move anterior and posterior direction, and from side to side direction, then upward and downward direction, and the abduction and adduction, and of course, flexion, extension, and rotation. But most of you must be knowing the knee joint is a modified hinge joint, which allows only flexion and little bit of flexion and extension and little bit of rotation. Therefore, the joint stability is very important in knee joint during walking. Normally, in any joint, the stability of the joint is maintained by bony congruity, muscles, and ligaments. In the knee joint, the bony congruity hardly contributes to the stability. So the muscle strength and the ligaments are very important in keeping the joint stability. If the muscles around the knee joint are weak and the ligaments are lax, then the stability of the knee joint is hindered. And again, during walking, to have a proper smooth walking, the movement has to be maintained in a proper way, proper combined or coordinated way. This is done by coordinating the muscle activation and inhibition very smoothly. This diagram shows you that while during our gait cycle, the degree of knee flexion happening in our knee joints. You can see the gait cycle has 2 phases: stance phase and swing phase. Stance phase means that when the foot is on the ground, and the swing phase means that foot is above the ground. So during the initial stance phase, after the heel strike, that means when you put your feet on the ground, there will be flexion of the knee, then followed by extension of the knee, and again flexion and extension likewise. So to have proper smooth contraction, now see, if you want to flex the knee, the hamstring muscles has to be activated and the quadricep muscle has to be inactivated. But during the next phase where there has to be extension, the quadricep muscle has to be inactivated and the hamstring muscle has to be inactivated and the quadricep muscle has to be activated. So this is the smooth functioning of the knee joint, or the locomotion is maintained by proper muscle coordination. If there's no muscle coordination, the forces acting on the knee joint will be very much, and there will not be a smooth contraction or the smooth movement within the knee joint. So locomotion will be very difficult. Then we'll talk about some general factors about osteoarthritis. Osteoarthritis is the most common type of arthritis worldwide. Women are affected more commonly than men. It is estimated that when people are above the age of 60, 1 out of 5 women and 1 out of 10 men are affected with osteoarthritis. Out of them, after the people who are affected with osteoarthritis, 25% of them are unable to perform their day-to-day activities normally. So you can see now, osteoarthritis of the knee joint is a very debilitating disease. And in Sri Lanka and in Asian countries, osteoarthritis of the knee joint is more common than other arthritis like shoulder arthritis or hip arthritis. These are some general factors about the osteoarthritis. Now we'll just talk about the pathophysiology of the disease. The arthritis is considered a disease of the whole joint. All the structures I told you earlier, the bones, the muscles, the articular cartilage, the ligaments, all these are affected from osteoarthritis. It's a biomechanical, genetical, inflammatory, and metabolic. It has metabolic etiologies. Because of that, there will be some structural changes. Structural changes of the bones, subchondral cartilage, ligaments, capsule, everything. So because of that, there will be pain. When there's pain, the patients will not move there. Initially, because of the pain, the muscles are inhibited. Because of that, there will be muscle atrophy. As well as when there's pain, normally patients don't want to move their knee joints. They don't want to move their joints, basically. Because of that one, there will be disuse atrophy of the muscles. So when there's osteoarthritis, the whole joint is affected. So this is very important in the management. There are several causative factors for the development of osteoarthritis, such as increasing age. When you are getting older, the chances of developing osteoarthritis is high. And as I said earlier, female gender is one cause, and genetics. This is also another cause. And metabolic diseases like diabetes, hypertension, dyslipidemias, obesity, all these causes can cause osteoarthritis. And previous injury is a major risk factor. If there's a risk, if there's a previous injury of a knee, then there's a 3.9-fold increased risk of developing osteoarthritis. And the other important factor is the biomechanical defects or biomechanical force transmission. When there's any defect in the force transmission, then they are more prone to develop osteoarthritis. If their BMI is more than 30, basically if they're obese, they have 2.6-fold increased risk of developing osteoarthritis. And if there are repeated stress on the knee joint, the most of the time, this can be due to some occupations like construction workers, where they have to kneel for a long period of time, or they have to lift heavy weights. Then they might have an increased risk of developing osteoarthritis. And in competitive sports participation, when they participate for competitive level of sports, then they are also more prone to develop osteoarthritis. And the other one is the bone deformities. If you have any kind of a bone deformity, like maybe knock knees or bowed knees or pes planus or pes cavus, then they are also having a high risk of developing osteoarthritis. Since competitive sports cause a lot of osteoarthritis, some people think that engaging in sports or running increases the risk of developing osteoarthritis. In a systemic review done in 2017, they have worried about the prevalence of osteoarthritis among the general population. They have found that competitive runners has 13.3% of them have osteoarthritis, and sedentary non-running people, 10.2% of them have osteoarthritis. And people who do recreational running, the people who run to maintain their health, they have only 3.5% of osteoarthritis. So this means that the relationship between the physical activity and the development of osteoarthritis is not a linear thing. Definitely, recreational running has some protective effect against the development of knee arthritis. So it's very important to understand if you continue physical activities not at competitive level, but at a recreational level, then definitely the chances of developing osteoarthritis is very less. When we consider about the clinical features, their main complaint is the pain. Most of the time, the pain is usage related. When they do any kind of activity, walking, when they try to get up from chairs, then they'll have some amount of pain. Worst in the end of the day, because since they have been working for a long period during the day, the pain is worst in the end of the day. The etiology of pain is a very complex thing. There can be joint-related factors, there can be extra-articular factors, as well as some nociceptive pathway sensitizations. And it is also found that people with arthritis, because of pain, they have sleep disturbances. And when they have sleep disturbances because of the OA, they perceive more pain. So for them, it's very painful. And most of the time, the people with OA find it difficult to continue their normal day-to-day activities, and they have been suffering from pain for a long period of time. So due to this reason, most of the time they are depressed. Again, when there's depression, their pain perception is very strong. So all these factors contribute to the pain of the knee joint, but it's a complex process. As I said, within the next slide, we'll discuss a little bit more about that. And apart from that one, they will say that they have stiffness of the joint, mainly in the morning times or after rest. They might have a small amount of stiffness, which lasts maximally for about 30 minutes. There will be loss of motion and there will be crepitations. Patients might say that when they අපි දැන් මම knee joint එක නමනකොට මගේ දණිස් ඇතුළට නිකන් චර චර ගන්නවා වගේ සද්දයක්. So this is a very common complaint. And the other one is the instability, and there will be locking also. Locking is due to there might be the small pieces of articular cartilage acting as foreign bodies, which causes the locking of the knee joint. And there will be swelling also. These are the main clinical features in people with osteoarthritis. And this is, as I told you, as I showed in the previous slide, the pain is a very complex process, and this is a diagrammatic representation of how pain is produced in osteoarthritis. Due to presence of risk factors and physical stress and reduction in their strength, muscle strength, there will be structural deformities, then which leads to peripheral and central nervous system sensitization, which causes pain. But also mind you that this pain is aggravated by psychological as well as socioeconomic factors. So during management, understanding of all these factors is very important. Then only we can manage their pain properly, because they come to us with pain. So we have to manage their pain. So understanding of this pathophysiology is very important. Then we'll move on to the examination. As a sports physician, we do examination by look, move, and feel method. So by just looking at the knee, the knee might be completely normal looking, and on the other extreme, it might be swollen with deformities. Like in this knee, there'll be bowing of the knee joints. There'll be muscle wasting, especially the quadricep muscles. And there can be some amount of malalignments, like leg length discrepancies, various deformities, or the foot deformities, like high arch foot or flat feet. So these also can be causative factors. So we have to look into those things. And while moving, since the patient is having pain, they have antalgic gait. They don't want to bear weight on that feet, that leg. And there will be decreased range of movement within the knee joint. Ideally, we should be doing a gait analysis. During normal examination of a knee joint, what we are looking at is the static stability of the knee joint. But what is more important is to assess the dynamic stability of the knee joint. Because, as I said earlier, during walking, high amount of forces act on the knee joint and forcing them to move in different directions. So if we can have a proper gait analysis, that will be the best. This can be done in a very sophisticated gait analysis lab with a lot of cameras and sensors. But this also can be done in normal our day-to-day clinics using a smartphone where we can uh, video their gait and upload that to a simple uh, 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 software like Kino. We have this very available freely, and we can assess their uh, the gait analysis can be done while they are walking. And the other one is the feel, how we feel the knee joint. There will be crepitation. There can be little bit of effusion. And normally the knee joint will not be tender, but there can be some ligament laxities, like mostly the lateral collateral ligament will be lax. There are no special tests to diagnose osteoarthritis. But as a clinician, we can do this Clark's test. But mind you that this is a very painful examination. So we don't normally recommend people to do this one. But by this one also, we cannot diagnose the arthritis of the tibiofemoral joint. We can see whether there's any patellofemoral joint osteoarthritis. This test again is not specific. If the patient is having any kind of a chondral injury at the patellofemoral joint, this test might be positive. What we have to do is the examiner has to press the upper part of the patella, and the patient is asked to contract their quadriceps muscles. If they have arthritis or chondral damage, they might experience pain. Mind you, again, this is a very painful procedure. So it better before doing that, better explain the patient what we are going to do. Then comes to the diagnosis. Diagnosis of osteoarthritis is a clinical diagnosis. There's no test or there's no investigation to tell us that this is the osteoarthritis. So generally, full blood count and ESR are compensatory investigations, and invariably there will be no. But we can support our diagnosis by doing an X-ray of the knee joint, which has to be weight-bearing X-rays. AP, lateral, and skyline view are the best to diagnose, to see the radiological changes of osteoarthritis of knee. So now we'll see what are the things we are going to find in X-ray in a patient who has osteoarthritis. Those are the marginal osteophytes, joint space narrowing, subchondral sclerosis, and subchondral cyst formation. So osteophytes are bony prominences or bony spurts like this. As I said earlier, when there's osteoarthritis, the stability of the knee joint is not there. So what the body does is to make this joint stable. To stabilize this one, there has to be large surface area. So to have a large surface area, what the body does is to make some osteophytes and make it more large. So there will be marginal osteophytes. If the osteophytes are somewhere here, then of course, we can't say that it's due to osteoarthritis. It has to be marginal osteoarthritis. Then other one is the joint space narrow. The joint space means that the gap between the lower surface of the femur and the upper surface of the tibia. As I said earlier, the forces transmit through the medial joint line, not normally through the medial joint line, not the lateral. So all the osteoarthritic changes will be more on medial side. If the gap, normally the gap between the femur and the tibia is around 5 millimeters. If it is more than 5 millimeters, we know that this is normal. But if the gap is less than 3 millimeters, then we are sure that there's joint space narrow. And the other one is the subchondral sclerosis. Subchondral sclerosis means just below the articular cartilage, there will be some more bone formation. You see, now the density of this area is more than the other part. This is again because of the force transmission, there will be more bone formation to support that one. So that is the subchondral sclerosis. And other one is the subchondral cyst formation. When there's articular cartilage damage, it's very hard to identify in this one. When there's articular cartilage damage, the synovial fluid creeps to that one and forms a small collection of fluid, which can be seen in the X-rays as a very radiolucent small bubbles. But it's very difficult to appreciate in this X-ray. So those are the main radiological findings you will see in a patient with osteoarthritis of the knee. This is the classification of the osteoarthritis of knee according to the X-ray findings. Clinically, this is not very important because we don't go by during management, we don't go by what the stage is. This is mainly for the research purposes, but it is divided from this Caligran-Lawrence classification, or simply we call it KL classification. Then the osteoarthritis is divided into 5 main categories. Grade 1, grade 0 is it's a normal knee joint. Grade 1 is we are having a doubt whether there's osteophyte or not. It's doubtful. So it's the grade 1. We are grade 2, there's definite osteophyte formation, but there's no joint narrowing of the joint space. In grade 3, there will be definite narrowing of knee joint with multiple osteophytes. In grade 4, there will be severe destruction with multiple osteophytes, multiple large osteophytes, and obvious narrowing of the knee joint, and with osteochondral sclerosis. Those are the gradings of osteoarthritis by Caligran-Lawrence or the KL classification. Once the diagnosis of osteoarthritis is made, we have to treat the patient. So treatment has mainly 3 components: education, pain management, and lifestyle modification. So the treatment starts with education. Most of the time, the patient have been seen by multiple doctors, and they have been told this is not a curable disease, and they have to be on drugs for the rest of their life. So most of the time, they are anxious, they are nervous, and they are afraid. So during treating the patient, reassure them initially by saying that this is a manageable disease. We can manage it. We can prevent your knee pain. So education is a very important thing. Educate them how obesity, lack of strength, or muscle coordination, muscle strength aggravates their disease process, and get them involved in the management process of this osteoarthritis. If you don't get their involvement, it's very difficult. As I said, most of them are elderly people, so it's very difficult for us to change them. And if you don't get them involved in the management process, it will be very difficult for us to manage the patient. So educate them, reassure them, and get them involved, and tell them that these are the causative factors. This will be the natural history of the disease, and we can manage if you cooperate with us. And the other one is the patient comes to us saying that I have pain. So we have to manage the pain. If we don't manage the pain, then we have not done justice to the patient. So management is done, the pain management is mainly done initially by NSAIDs. This can be oral NSAIDs as well as local NSAIDs. But mind you that these patients are in their 50s and 60s, so they might be having a lot of other comorbidities like diabetes, renal disease. So when starting them on NSAIDs, we have to be very careful. And duloxetine 60 milligram daily has proven to be very effective in the management of patients with osteoarthritis. As I said earlier, pain generation is a very complex process in patients with osteoarthritis. So this drug, the duloxetine, acts as a central acting NSRI. So it improves the mood, it improves the anxiety, and also it improves the pain. So these are the main, the way of managing pain in a patient with osteoarthritis. Then we'll we'll see about the lifestyle modifications. The lifestyle modification are mainly weight reduction and exercise. It is very difficult to change someone. We have to be, as physicians, we have to be very patient. All of these patients are elderly patients and they have their own pride. If we go and tell them do this and do that, they will not like it. So we have to be very patient. One goal of reducing the weight, one goal of our lifestyle modification is reducing the weight. Right now, again, these patients must have been told by a lot of people and lot of doctors that you have reduced weight, and they must have been trying for a long period of time, but without any proper improvement. So appreciate what they have been doing up to now, and get the help of a nutrition physician if need to manage their weight, and tell them that if you reduce your weight by about 10%, only by about 10%, I hope you can see my pointer, then there will be a 50% improvement of their pain. If you tell them that if you cooperate with us and if you reduce your weight by about 10%, then without any other drug, without even the NSAIDs, their pain will be reduced by 50%. So tell them. And and by doing that one, we can give them some hope. So they'll be happy now. They have some kind of a target. And again, when we tell them to exercise, it'll be very difficult. Some people think, since I have a joint problem, it is not good for me to do any exercises. So reassure them by saying that it's not only safe, but also if they do any exercises, the pain will be less, the fatigue will be less, and inflammation and the disease activity will be less. And we normally prescribe them. We'll go through the exercises one by one in the coming slides, but we prescribe the exercises according to the FIT principle. FIT stands, F means frequency, I mean intensity, T time, and the other T is time. If we just go and tell them, go and do this exercise, go and do that exercises, they will definitely not do it. We have to tell them, do these exercises. This is the frequency. This is the intensity, how hard you have to do this. And this is for this much of a period you have to do it. And this is the proper exercise, the proper way of doing the exercise. Likewise, we have to advise them. And we have to tell them that they might say that I have knee pain. So do the exercises, start doing the exercises during the day where the pain is minimal. If you have severe pain, maybe in the morning times, then don't do the exercise in the morning. If you have less pain during midday, start exercise during the midday. And the other one is, if they complain that they have more pain after the exercises, after 2 hours of exercise, than prior to the exercises, then definitely the intensity and the duration has to be reduced. The other important thing is, start low. The intensity has to be very low and progress very slowly. Otherwise, if they experience severe pain, they will stop doing all the activities. These are the exercises that we are going to do, and we will be talking each one of these individually. We will be doing muscle activating exercises, muscle strengthening exercises, the exercises to improve their balance, their coordination and proprioception, and ultimately improve their range of movements. By these exercises, our aim is to increase the stability of the knee joint through increasing the strength of the muscles, and increase the mobility through balance, coordination, and proprioception, and to reduce pain by doing the exercises, and by reducing the weight, we are planning to reduce their pain also. So this will be our management plan. Now we'll go for the individual exercises. one of the best exercises to activate the quadricep muscle, the muscle in the anterior part of the knee, is this exercise. We ask the patient to lie down on a bed and have a towel or a sandbag or anything under the knee joint. And what we ask them to do is to contract their quadricep muscle properly and hold it. When they contract the quadricep muscle, ideally the foot has to be raised from the ground level. Initially, they might find it very difficult to do. They might say it's very painful and that their foot might not raise from the bed. So what we can do is ask them to feel their quadricep muscles. When they contract, in the sense when they try to push the towel onto the mat or the bed, they will feel that there's a contraction of the quadricep muscle. Start with that. Initially start with that one. With time, they will improve. Now, as I said earlier, frequent. How frequently they have to do it? Whether it's once a day, twice a day, maybe once in 2 weeks, is how frequently they have to depends on the patient. We cannot decide on a frequency proper. Ask them whether they can do it daily, they can do it 3 or 4 times a day, and the intensity also the same. How hard they have to contract. As I said, initially they might not be able to raise their foot out of the ground. It's just the contraction initial. So intensity again depends on the patient. And how long do they have to hold like this? Ideally, if a normal patient can do it, what we say is they have to contract the maximum contraction they can do and hold it for at least 10 seconds and relax them and repeat the same exercise for about 10 repetitions, which is called one set. So when they do 10 repetitions, it's a one set. So have about 2 minutes gap between the other set and start doing the second set, 10 repetitions. Likewise, what we say them is to have at least 3 sets. Ideally daily, or if they can do it 3 times a day, it's much more better. But all those depends on the patient. If they say, I can do only 1 repetition, only once a day, accept that. Accept and tell that patient, okay, we'll start with this one, but gradually we'll increase the intensity and the frequency. And the other one is the muscle strengthening exercise. This is the same simple exercise again, single leg, straight leg raise without the weight initial. So during both of these exercises, we don't ask them to bend the knee straight. So the pain is very minimal. So what we can ask them to straight the knee maximally for about 30 to 45 degrees. And again, hold it at least for 10 seconds and put it down. Likewise, 10 repetitions, 3 sets. This is the ideal thing, but discuss with the patient and according to the FIT principle, give them whatever comfortable with them and gradually increase that one. Initially, they raise their leg without any weight, but once they are comfortable with that one, we can apply some amount of weight. Maybe start with 500 milligrams and gradually increase the weight. And yeah, one other exercise, the same way, we can ask them to laterally rotate the foot while they are straightening their leg. By doing that one, they are activating and contracting the VMO muscle, the vastus medialis obliquus muscle. So this is the second exercise that we promote them, and with the subsequent visit, we try to overload them with the weight. But when they come back, if they have not done the exercises properly, just see what they have been doing for the last 2 weeks. If they have not done it properly, don't increase the weight or the intensity. Just ask them to continue the same exercise, but teach them the proper way. The other one is again a simple exercise, sitting on the chair and asking them to raise the leg. In this exercise, there will be movement of the knee joint. So they might experience little bit of pain. Tell them that this might be little painful, but since they start without any weight, this might not be very difficult. If they say that they can't maximally extend like this, no problem. Ask them to do it the way they can. The maximum amount of exercise that they can, hold it for the maximum amount of time they can, and put it down again. Ideally, as I said earlier, three sets with 10 repetitions. Ideally, they should hold for about 10 seconds also. When they are comfortable with this one, increase the intensity by adding some weight. These are the basic things. And the other very good exercise is to ask them to sit down and stand. This is as equal as the squatting exercise. But for that, when they go down, they have to sit down on a bench or a chair. This is again a very good exercise. Ask them to sit up and sit down and get up. Likewise, do at least 10 repetitions. If they can start with one, that will be good. 10 repetitions, 3 sets. That is our ultimate goal. But we can progress further when they are comfortable with this one. The other very important exercise is the balance exercise. Normally, they know about the previous two exercises, the activation and the strengthening exercise. But most of them do not know about this balance exercise. So we have to have proper balance, proprioception, and coordination for the management of osteoarthritis. So initially, what they ask them to do is to have their normal, comfortable standing position with eyes open. Stay there, stay like that for at least 1 minute. They find it very difficult to stay like that for 1 minute. They will say, I have some vertigo-like features. So this is very good for them to start. And when they are comfortable with that one, ask them to close their eyes. Then by closing their eyes, we are incorporating this proprioceptive mechanism. So their proprioception will be much higher. So we can gradually progress that one into more difficult things like standing on one leg with eyes closed and some complex movements like this. These are gradually increasing up to this level. And when they are comfortable doing something like this, we can ask them to stand on a not a very hard surface. Soft surface also we can incorporate into the exercises. Cycling is very, very helpful for patients with osteoarthritis. But some people find it very difficult because of the pain. And we recommend normally a stationary bicycle, not the normal push bicycle, because when they ride the push bicycle, if they don't have balance, they might fall. So riding on a stationary bicycle is very helpful for the osteoarthritic patient, but we find it very difficult because a lot of Sri Lankans can't afford that one. But if they can do it, it's very good. It improves the muscle strength, improves the muscle endurance, as well as improves the knee joint range of movement. So if they are capable of doing any kind of stationary cycling, please do encourage them. These are the starting exercises we normally recommend for the patient with osteoarthritis of the knee. Then the other interventions that we do for the people with osteoarthritis of the knee. One is giving intraarticular, one form is giving intraarticular injection. One of them is the PRP injection, platelet-rich plasma injection. Very little amount of literature is available on PRP injection, and they suggest that it's beneficial. They reduce pain and improve the function. But from our experience, we find that it's very, very effective. But mind you, we don't use PRP alone. We combine PRP with exercise program as well as the weight reduction. So they have they say that their pain has gone down. Some people even say within about 1 month, their pain has gone down from about 70%. So it's very effective. What we do is we give 3 doses of PRP at least 2 weeks apart, depending on the availability of slots. Because sometimes after giving the first injection, they might have to wait for about 1 month to get the second injection. This is not done alone. When the patient comes to our clinic, we draw 10 milliliters of blood and we send that blood to the blood bank, and they prepare this PRP. Around 5 to 6 milliliters of PRP we can extract from this 10 milliliters of blood, and we inject directly into the knee joint with aseptic sterile condition. So we find very, very good results with that. This is better for early OA rather than going for grade 3 or grade 4. Better for 1 or 2, grade 1 or grade 2 OA. And the other one is corticosteroid. It's good for a short period of time for pain relief, but repeated long-term use of steroid is not very good because it can cause some condyle damage, articular cartilage damage. So we normally give corticosteroid till the PRP is available. Once the patient comes to our clinic, we might not be able to give them a PRP straight away. So sometimes we give them corticosteroids till the PRP is available. The other aspect of the management of the osteoarthritis is intra-articular injections like hyaluronic acid. The evidence does not support the use of hyaluronic acid. The evidence says this is not very effective, but some people comes to us saying that their relations, their known person has taken this injection and it has worked for them. So if the patient asks for the hyaluronic acid injection, we don't say that no, but we don't normally recommend that one because it does not have any evidence to support that. The other one is the supportive therapy, like knee guards, using a cane and knee braces. And if they need lateral heel raises, these are very good measures for them to have a proper biomechanical transmission of force so that the pain will be reduced. So these are other modalities that we use to manage patients. And of course, supplements, glucosamine, chondroitin sulfate, and fish oil. Research have shown that there are no beneficial effects on these drugs. But some people say, since they have been taking this medication for a long period of time, they say this is good for us. Then we don't discourage using them. But if a patient has never taken this one, and we don't encourage them to take it because there are no beneficial effects. But if they have been taking that one, we don't discourage also because I could not find any research saying that these are harmful. So we don't discourage. We don't normally discourage if they are using that one, but we don't encourage also. And the last thing is the surgical referral. When we do surgical referrals, when the conservative management fails, it doesn't matter how severe the disease is, whether it's grade 1 or grade 2 or grade 4. We don't just refer the patient with grade 4 osteoarthritis. We just don't just refer them to the surgical options. We initially try to manage them, the medical management. If that fails and there's worsening pain and severe functional disability, then only we consider send them to surgical referrals for maybe total knee replacement or high tibial osteotomies. And lastly, if we don't talk about the preventive approach, then in osteoarthritis, then my talk will not be complete. In managing osteoarthritis of the knee, preventive approach is more important than the curative approach. So prevention can be divided into primary prevention as well as secondary prevention. Primary prevention where they have not had any kind of a disease process. So injury prevention is a very important thing, and they have found that in 2018, obesity prevention in adolescents is very effective in preventing development of osteoarthritis. The other one is increasing the muscle strength, coordination, and proprioception with balance. These can be achieved by proper exercises or participating in sports. So encouraging them in doing exercises and participating them in sports can prevent development of osteoarthritis. The other part is the secondary prevention where they have had some kind of injury to the knee joint, but still they are not having osteoarthritis. So educating them about the weight reduction and the exercises and supportive devices, giving them supportive devices, can prevent the development of osteoarthritis. So thank you very much. Hope I could teach you something, and I am happy to answer if there are any questions.
Yes, sir. Thank you very much for that wonderful lecture. We have learned a lot. I think you have enlightened a lot of us. There are many questions posted priorly also. And at the moment in the live chat, there are no questions posted. So I think we can conclude as the time is also in restraint. And there are some questions already asked from our members priorly. So, sir, we will give those questions with the contact numbers and email addresses to you, and you can answer them leisurely in the leisure time. Moreover, I wanted you to remind you that the link will be posted here, where you can go and fill the Google Sheet, and out of that you can receive the certificate which you are eligible to from this session today. So once again, I wanted to thank Dr. Mithila for this great opportunity that you have given us, and partnershiping with Shri, and we hope to see you in the future also with many more interesting topics, something like that what you have done today. As the last remark, again, I wanted you to remind to fill the link in the chat box, and as well to receive your e-certificate for participation. Thank you very much, sir, once again for joining today with us. If there's anything that you can tell to our participants, we had more than 120, somewhere around 130 participants today, which is a big amount, and it shows that how important this topic is, sir. Thank you very much, and we hope to see you in the future also. And also to all the participants, I want to remind you, and I want to urge you and invite you to join with us the next week also. Thank you very much, sir.
Thank you.